solidaire européenne de demain. Et j'invite à participer Nathalie COLIN-OESTERLE, Antoine FLAHAULT, Philippe JUVIN, François KRABANSKY, Véronique TRILLET-LENOIR et TUBEUF. Je veux dire bonjour à toutes et à tous. Vous êtes 5 en télétransmission et 1 sur le plateau. Donc bonjour et bienvenue à CHAM 2020.
Bonjour.
Bonjour. Alors l'économie, bonjour, tout le monde est connecté, on y va. L'économie sociale et solidaire associe l'efficacité des moyens techniques mis à disposition à leur égalité d'accès. La santé est donc, si on regarde, la plus belle des économies solidaires. Je voudrais qu'on revienne sur plusieurs thématiques de solidarité que nous avons abordées, notamment avec le ministre des Solidarités et de la Santé, Olivier Véran. Je répète, la présidence de la Commission européenne, dans son discours de l'Union, a plaidé pour une plus grande, avec grande conviction, pour plus d'Europe de la santé, notamment afin de prévenir, de traiter de façon communautaire les crises sanitaires. Il y a 2 ans, lors d'un CHAM, nous avions dit qu'il faut créer le GIGS, le groupement d'intervention et de gestion sanitaire européen, comme le GIGN des gendarmes. 200 ou 300 spécialistes formés à l'irradiation, aux épidémies, aux accidents industriels, aux accidents agroalimentaires et autres, capables dans l'heure de se rendre sur les lieux pour aller analyser la situation et éclairer le politique. Qu'est-ce que vous en pensez?
Enlighten political leaders in case of an emergency crisis. What do you think of it? Nathalie COLIN-OESTERLE.
Vous nous entendez?
Can you hear us? Sorry, I'm sorry, I didn't hear you.
Vous n'avez pas entendu la question?
You didn't hear the question? Désolé, non. I'm sorry.
C'était pour savoir ce que vous pensiez d'un groupe d'intervention sanitaire comme le GIGN français en gendarmerie pour aller éclairer la situation de crise, qu'il s'agisse d'une pandémie, d'un Tchernobyl, d'une vache folle ou du concombre espagnol qui était en fait venu d'une ferme bio-allemande. Donc, comment fait-on en Europe pour essayer d'arriver à régler ces crises?
So how do we manage to solve those crises in Europe?
Je suis l'auteur d'un rapport.
I did write a report.
Oui, très bien.
Yes.
Je suis donc l'auteur d'un rapport.
So I did write a report that was voted in the European Parliament about shortages of medicines, and we are asking more
mais également davantage de coordination.
Money, of course, on health, but more coordination and cooperation between member states in order to be much more powerful, to have more striking power in case of those pandemics. We've seen how much it was important to find some European sovereignty, and it is up to the European Union to coordinate national actions in order to guarantee citizens a quality health policy. So we need more means, obviously, but more cooperation, coordination, harmonization of policies. So in the European Parliament, you are going to push forward this type of proposals. Véronique Trier-Lenoir, are you along the same line? Yes, absolutely. I'd like to add 2 things.
Nathalie, que je salue.
In view of what my colleague Nathalie just said, and I'd like to say hello. In fact, that system was already in place, and it's been activated lately and in an awkward way, in a disorganized manner at the very beginning of the crisis. There is a European body of health. There is a European civil protection mechanism for transfer of goods, staff and patients. Those mechanisms had been designed in a naive way, even an arrogant way, to try to help third parties and countries, not European countries. So they've been activated in an emergency in order to solve a problem that was domestic to the European Union and not to call upon external European solidarity, but an intra-European solidarity. The second comment is obviously the Parliament is promoting that solidarity and coordination. It has done it very early on during the first resolutions in April 2020, when the Parliament unanimously voted with a great majority a European mechanism for health response, including the medicines, like Nathalie said, but also mechanisms for preparing for crisis, whatever they are. They could be environmental, toxic, food crisis, and there should be a strengthening of the European mechanism. So the tools are available, and like the minister said, rightly so, what is lacking is a structure. And I would like to talk to him about this, a structure that could coordinate and make this efficient. So we're talking about a GIGS that we should launch. Philippe Juvin would like to say something. Now, in the Treaty for the Operation of the European Union, under Article 38, it does state that the European Union has competence for health issues. Now, policy is an art of execution. It's easy to think about big principles and structures, complicated ones, but the real issue is how do we implement it? I've been a European MP for 10 years, and I've seen many resolutions about the Europe of health and many things that would help us to respond very quickly. In 2006, Michel Barnier, so that's long ago, made a report about the civil protection, European civil protection. But so there are things that are available, but the question is, why are we talking and voting resolutions but not moving forward? When the Belgians were attacked during the crisis, during the attacks, 100% of their hospital structures were used, and if there was to be a second attack, they couldn't have reacted. So if Europe wants to move forward, it has to make concrete achievements. And there was a proposal a year ago that we could go back to in order to fulfill the mission to, for example, have 5 or 6 trains, health trains, everywhere in Europe that would be locked when we're not using them. But the day we have a problem, we use them, and because trains can go everywhere in Europe. And so the concepts are available, but practically speaking, how do we do it? So I believe that we need to focus now on small, concrete achievements. That's how we can move forward. Okay, I understand that, but is it so difficult to have that group of 600 experts for the different items that I've mentioned that could gather in 1 hour and go on the spot, assess the damage, and enlighten the political leaders with rehearsals, you know, like the military people are doing, to be trained to do that? It should be possible to do that in Europe. Yes, you're right. François, I would like to say something.
Qui est très intéressante. Il y a quelque chose qui a été soulevé puisqu'on parle de santé et d'intervention en santé et des moyens. Savez-vous qu'aujourd'hui, en France et a priori en Europe, on met la quasi-totalité de nos moyens sur ce qui
allocating all our means on what is having a 25% impact on the health of citizens. Why am I saying this? A study was conducted in Canada about the influential factors on health. And the health system, the medical care is impacting 25% of the health system, while these economic, social, and environmental environment would have an impact on 60% of the health. Having said that, if we talk about concrete systems, concrete organizations, we need to have a culture about, we talk about prevention, it's very good. We need to continue to have prevention, but if we invest on prevention, we are going to be late, because we need to go one step further, which is promoting health. What is promoting health about? It means that citizens will be autonomous in terms of the health. They can make their own choices, they can adopt the right behaviors, and they will know how to react if they are faced with a disease. Behaviors is having an impact on, is having a 37% impact on health. And the second thing that is very important, which is that in France we are a nation of public health, but if we could be a Europe of public health, contrary to what is often said, public health is not everything but care. You know, what we heard is a good example of it, but it is also about the economics and solidarity, housing, etc. So let's have that public health approach, and then with a more concrete framework, we'll be able to take those actions. Antoine, Flavio, what is your view on this?
Sur cette task force dont tu parles,
about the task force that you're talking about.
Le Conseil scientifique
I believe that the Scientific Council for the COVID pandemic has been playing that role. It's good to have GIGA, some types of RAID group, but it's also necessary to have an interdisciplinary team, an independent one with an in-depth thinking. It depends on what we're talking about, but we're talking about health disaster like the one we are experiencing at the moment, or a big pandemic that is emerging. The fact that we have different sectors, not only academic sectors, but different sectors of activity in the country. The fact people from the private sector, from civil society, political leaders, the fact that all these people will think on a jointly basis about the problem, I believe that's central. Now,
étonnant que personne n'ait mentionné
l'ICDC.
On a un European Center for Disease Control.
The European Center for Disease Control is based in Stockholm. And European countries, in fact, are not giving all powers to this ECDC in case of an emergency crisis, like WHO. You know, we're not giving the power to the conductor because we don't want to be coordinated. European countries want to keep their national prerogatives, and they don't want these organizations to encroach on those prerogatives. And the ECDC is not receiving the power to come to your country and carry out an independent investigation or criticize you or criticize any local policy that they would consider to be not adapted. If European countries really wanted to have an actual coordination of the health at the European level, in case of emergency, they would need to give the power to the European Center of Disease Control. I think that's what Mrs. von der Leyen said. I think she insisted upon the fact that ECDC should be reinforced, and she also said that a research authority like the American BARDA, that it should be created. Do you think that we should add this type of structure?
Oui, simplement pour revenir un petit peu sur ce que j'entends.
Just to come back to what I'm hearing.
Je ne crois pas que nous soyons dans les concepts, je reprends ce que disait Philippe Juvin.
I would like to come back to what Philippe Juvin said. We've tried to make very concrete proposals at the European level. We're talking about agencies. One of the proposals is to reinforce the roles played by agencies. Now, you're right to say that it has to do with the willingness of member states, and this goes beyond the European Parliament. Now, concrete proposals have been made
by my colleague Véronique
Véronique or myself. on that strategic reserve, that emergency European pharmacy that we could create, the fact that we would have our sovereignty with the European Agency of Medicines to regulate stocks in member states, or to provide more transparency of the distribution chain. It's not a catalogue of good intentions, you know, but we've put some very concrete proposals on the table with the creation of different pharmaceutical European bodies, not non-profit organizations, to produce what laboratories consider to be not profitable anymore.
Philippe. Oui.
So we made very concrete proposals.
D'abord, toute proposition du Parlement, si elle n'est pas prise par les États membres,
Parliament, if it is not being adopted by countries, it's not going to work. So we could make lists of desires or good points, but it won't work, and that's what we've been doing. When you start asking for trains or civil protection at the European level, it is not being done. The second point, and I fully agree with what Antoine Flavio said, the fact that countries don't want to provide data. We've seen that for each crisis, the mad cow disease, for example, countries do not provide data. Look at the European Commission side. When the COVID crisis started, the European Commission gathered member states with a technical meeting. There's a report every week. You can see it on the website with the 27 member states around the table. And on January the 27th, the European Commission asked member states, are you having supply issues on individual protection equipment? Everybody had problems. But what did they answer? Only 4 countries out of the 27 said, yes, we do have an issue. And the other one said, no, everything is fine. So it is showing that member states are not reporting their issues, their problems, because like Antoine Flavio said, they don't want the European Commission to go and look at what's happening in their country. So we could vote everything in the European Parliament, legislative points, directives, regulations. If member states are not playing the rule of the game and are not implementing or not providing the data, it won't work. Véronique Trier-Lenoir.
Alors, je ne partage pas une certaine forme d'euroscepticisme.
Don't agree with Philippe Juvin's Euroscepticism.
En accord avec ce qui a été
I
dit
fully
par
agree with what was said by Mr. Flahault.
Actuellement, des agences sanitaires
we do have European health agencies. We have many of them. Not only the ECDC, not only the European Agency for Medicine. We also have an agency for health at work, for food safety, for the fight against environmental contaminating toxicities. So we do have the tools available, and we're not talking about implementing complicated structures like in previous mandates. We're talking about boosting, having an impetus. The Parliament will play its role, and we have committed ourselves. The European Commission, as you said, had made a strong case about that. And I heard a Minister of Health from one of the major member states saying that he was in favor of going towards the integration of national health policies into a big European system. So we need to increase the competencies of agencies and of the Commission. We need to have member states on our side. We need to have them committed. If we have France and Germany already, we will be able to move forward. And we need to have the European Parliament being the representative of citizens who want to have that Europe of health, and we will send the results. I have a question from one of the participants. Can we expect that member states
en matière de santé à l'avenir avec une Europe qui s'intègre de plus en plus, ou est-ce un rêve complètement fou
keen
et un
to
délire
stick to their
de pauvre
sovereignty,
qui n'y
or
comprend rien?
is it just absurd and because I'm a poor doctor and I don't understand anything? Even strong member states like France and Germany have fully understood that their sovereignty in the field of essential medicines, essential drugs, that it would go through a network of European dynamics. And it is an illusion to believe that on that topic, like on other topics, it is an illusion to believe that a member state alone can provide his health or its health autonomy.
Oui, bonjour. Moi, je pense sincèrement que la plupart des pays, en fait, se sont rendus compte qu'à plusieurs, ils étaient plus forts. La France a fait appel à l'aide
that they were
internationale
stronger
pour
together.
les patients.
France has
Et je
called
pense que la
upon
situation qu'on a vue
some
ici,
other
elle
countries
s'était jamais présentée
for
auparavant à ce point-là en
patients,
Europe.
and
Et
it
on était face à
was
une situation
unprecedented.
d'incertitude où aucun pays
So
ne savait vraiment
no
comment
country
réagir.
in
Et au
Europe
final,
knew
on a tous
how
réagi
to react. And at the end of the day,
comme
we've all
l'Italie.
reacted
On a
like Italy,
posé
like the
une
first
règle
country.
uniforme, par exemple, où
For
les
example,
hôpitaux ont
we have
décidé
decided that
d'annuler, par exemple, des soins non
hospitals were
essentiels.
going
Et je
to
pense que
cancel
derrière, il y a des
non-essential
stratégies de
treatments.
que certains pays
And
connaissent bien
I
quand ils
believe
ont
that,
connu des tremblements de terre,
you know,
quand ils ont
countries
connu,
that
en fait,
have gone through
des catastrophes
earthquakes, for
naturelles.
example,
Et là, l'Europe, finalement, a
natural
été soumise à une
catastrophes,
catastrophe qui était plus
they
grande pour toutes les autres qu'elle ait
know
connues. Et
how
donc,
to react.
elle doit
And
mettre en place
Europe
nécessairement
has
une
been
solidarité dont vous
hit
parliez au
by
début dans votre
the biggest
introduction,
catastrophe.
puisque je pense qu'en fait, on s'est rendu compte
And I
qu'on
think
a
that we've
besoin des
realized
plus
that
forts.
we need the others to be stronger.
Philippe,
Philippe,
Antoine,
sorry, Antoine.
vous voulez s'exprimer?
Oui, merci.
Yes,
Guy,
thank
non,
you, Guy.
En termes d'espérance de vie,
As far as
les pays
life
européens,
expectancy is concerned,
de l'Ouest
European
sont à peu
countries
près à
from
égalité.
Western Europe
En
are
termes
on an
d'espérance de vie
equal
sans
footing. In
incapacité,
terms
il y a
of
pratiquement plus de 10
life
ans d'écart
expectancy without
entre
any
un pays comme la Suède et un pays comme la France. Si on veut faire
incapacity,
une
there's a
intégration, qu'est-ce que
10-year
c'est que l'espérance de vie
difference
sans
between
incapacité? C'est la capacité d'un
France and
pays à amener
Sweden.
le
It is the
plus loin
ability of a
possible dans la
country
vie des gens en très bonne santé, et puis après,
push as long as possible people in very good health and help them to receive proper treatments till they die. So it's good to promote that type of life expectancy. But are we ready for that in France? You know, there are different lobbies. For example, let's take the example of alcohol. Are we ready to adopt the Swedish model? You know, we often hear that the Swedes are very relaxed. You know where they buy their alcohol? In government stores, in government shops. It's a nationalized system because they had an alcohol problem, so they've decided to nationalize the alcohol distribution. So they buy the alcohol in their liquor, they buy it in a government-owned shop. So are we ready to do that in a country where the alcohol lobby is so powerful? Because alcohol consumption is twice higher in France than in Sweden. Antoine, do you want to go and buy your whiskey in the police station? Well, during opening hours, you know, not on Sundays.
C'est justement ce que j'illustrais, c'est-à-dire qu'on peut avoir ce type
No, I think that's a good example of what I was talking about.
Des sujets comme la promotion de la santé,
You know, promoting health
sont toujours libres de leur choix.
means that people are free to take their to make their own choice.
Je pense pas que ce soit le genre de solution qu'on souhaiterait avoir en France. On est un pays
I don't think that should be the solution for France. We see that the lockdown was quite complicated. People want to meet with each other and celebrate, so let's not be too strict, too rigid. But now for the European agencies, there are many of them. There are many agencies in France. We've managed to regroup some of them. If we want to take global action on public health, we need to have a one-stop shop. You know, we need to have one single agency. Otherwise, it's pointless. You cannot don't have infectious disease on one hand, medicines on the other, and something else that is very important. Let's be careful about centralization. We already have great difficulties with national decisions that are difficult to implement in the regions, and we are saying that we need to give back autonomy to the territories so they can be efficient. So let's not make the same mistake at the European level. There is an interest for public health policies at the European level, but let's not. But let's be careful not to centralize too much. Now, the same question that I asked to our minister, Mr. Olivier Véran. Solidarity means that we need to reduce waste, and I know that this 20% mentioned by the OECD, and when I was practicing, it was 40 to 50% of useless procedures, endoscopy, for example. And since medicine is less and less invasive, it is being sold better and better, and not necessarily for the right reasons. So could we envisage that we would have an evaluation scheme, a European evaluation scheme, because the quality of the result for prostate ablation because of cancer should not be so different from between Brussels, Madrid and Paris? Why do we still have national agencies looking at quality while we could have a European agency working on the same topic? Sandy?
Oui, bah, moi je veux bien puisque moi je suis économiste de la santé.
I am a health economist. I did work in England. I've worked in France, and I'm working in Belgium. So I see how the health technology assessments are being done, the way it's going to be assessed on the economic level and also the efficiency. Everybody is trying to have a similar framework where we're going to use the same clinical data, look at the efficiency of the treatment. But there are big discrepancies. In England, for example, they have decided to tell how much they would cost versus their budget. But for other countries, it's difficult to give an economic assessment, to give a price. So we need to dare to say, okay, we're paying for health, and that's why we can pay, because we only have one budget. And the second thing is negotiation, price negotiation. Each country wants to negotiate the price, and they don't want to give an idea of the price that they're going to pay for the medicine. So there's a cultural obstacle, and there is the price, which is a problem. Who would like to say something?
Philippe et Antoine.
Philippe, Antoine.
Je pense, Guy, d'abord que tu as absolument raison.
I believe, Guy, that you're right.
Les pays de l'Union, s'ils veulent
member countries, if they want to benefit fully from the European Union, they need to homogenize their practices and their legislation. But in reality, very often they're using a way to escape the law, and we've seen that on a clinical test. It's a directive from 2001, leading to the fragmentation of the European law. There is a directive that was passed in 2001, but member states do continue to work on their own. In Italy, for example, there were 250 CPPs. It was incredible. So in 2014, we decided to have a regulation with immediate application without possibility of any interpretation. So I believe that at the European level, when Véronique TRILLET-LENOIR is saying that I am Eurosceptic, I am not Eurosceptic, but I think we need a more integrated union. I think we should have less directives, more regulations to force member states to move into a framework that they are saying they want to move into, but they escape all the time. So to force them to move into that framework, we need to move from directives to regulations, because it is binding and nobody will be able to escape.
Antoine.
Antoine Flahault and Véronique Lenoir. Thank you very much for mentioning these examples of waste. An OECD survey revealed that not only in France but across Europe, people are not favorable to a restructuring, reshuffling, and reviewing of their healthcare systems. And I think we were talking about life expectancy recently. I think we've made quite a number of steps forward there, but this, I mean, colossal waste, 20% of healthcare related expenses amount to waste. So what's happening is that everybody has to make sure that things on the local basis are orderly, and they have, everybody's got to take care of their own local issues and make sure that their house is orderly. So can you imagine that when it comes to the cost of healthcare, when it comes to the cost of drugs, we're talking deltas by a factor of 3 price-wise. So same again, some of these drugs are way more expensive. So between France, Holland, Sweden, so the cost of drugs really are on a country-by-country basis and can be dramatically different. So physicians have to make sure that their house is orderly, that every country has to make sure that their house is orderly, and so as to avoid these gaps. And what's useless is, and it's really interesting, because you can imagine the impact of the lockdown. And with our economist peers, they can issue views on the matters, but in terms of opportunities and mortality, we have, during the lockdown, fewer medical acts were performed. So we need to invite around the table people who are not within the medical field, because people tend to be very parochial and become very parochial, defending their own field of specialization. And this has to be part of healthcare-related expenses. Now, it seems that fewer cardiac arrests have or did take place during lockdown, and 50% fewer premature deliveries during the lockdown as well. Now, to come back to Europe, we all have our own focus of attention, and so the catchword, the byword really is that of the fact that you've all insisted on the absolute necessity to attend to the evaluation of the performance and the effect of drugs, and this will lead to harmonizing their price. It is hoped. But care, more generally speaking, as care is the byword, here we need to make sure that for the European Union, we have to have recommendations. These are never evaluated and they're hardly applied. And we have to apply across Europe criteria that will allow not to authorize but to recommend that some establishment take care of, let's say, cancer surgeries more than others. And so, again, beyond care across the European Union, we need and we must mention this as well, just to reiterate these. On these aspects of reorganization of healthcare prevention, we need to act European-wide, on a European scale. There has to be quality assurance across Europe, and Romania could inspire, could develop systems akin to our systems, or other countries could get inspired by the quality of the surgeries, but we could get inspiration from Nordic countries in terms of care, healthcare management, and efficiencies, as we're very hospital-centered here, as opposed to community healthcare centers. So we need to be able to evaluate the efficiency, and we have to have agencies that have prerogatives as given to them by nations across Europe. When we get into, when we talk about principles, everybody agrees, but when we get into the nitty-gritty, then people start disagreeing. Look at the Glasgow hospitals, look at their infection rates of their hip prosthetics and hip surgeries. We think extremely simple things that can be done. And in 30 years of surgeries, have never been evaluated. And patients could receive questionnaires to fill in. I've been the chair of the European Research for the Treatment of Cancer, and I received a letter indicating where can we come and evaluate in a month's time. So I received one Dutch and one German colleagues, and they would both side one file, and a couple of hours later they got back to me and said, well, yeah, you're doing well here in that respect, but in other areas that could be better. So, if you have peer-to-peer review, you automatically want to do better. You want to, to really get inspiration and to do your job, but better, even better. So when it comes to constraints, now what hinders us tremendously is constructors. You want to get to attain objectives in terms of surgical protocols, and you get evaluated, and then you're like, okay, you've met such and such objectives, and if that is not the case, how do you go about this to do your job, but better? So this is more a kind of systems that entice people, that encourage or empowering people so as for them to do their job better. And as opposed to having very squared away systems where people, have a choice. Either they get in there and they apply the systems, or they don't. So you're absolutely right. One of the challenges, for European-wide evaluation is that at the national basis, evaluation has to be relevant to start with. So let me explain. We are evaluating on the basis of resources, not on the basis of results. And so we need to be focused on results. So there has to be an extremely simple indicator. If, in terms of fractures of let's say in the femoral region well, and there has to be an indications across the regions in France. So no consequence, no sanctions, but maybe we'll have to have a transparent result, and this should be enough to increase, to drive the quality of healthcare. We never judge on results. We are always evaluating on the basis of resources. That's what's wrong about the system.
La connexion fonctionne bien.
Moi, je suis tout à fait d'accord. Je pense que c'est works well. So I do think that these are resources all the way to results. So whenever you set objectives, maybe at times you're counterproductive. And so this, again, has to be taken into account. Maybe the idea of having a European medical file. So why do we have la carte vitale in France? And the NI identity card, so maybe I would like to have the Vesal card. One of the iconic physicians in the Renaissance who cared for, who provided healthcare to Henri II. And Ambroise Paré tried to save the king when he was wounded in Paris and died 2 days later. So for whatever reasons, in the member countries, why do we not have a European-wide file? And why have we not got a European-wide system? Despite the vote on the European directives for the rights of patients that was back in 2011, nobody wanted to take care of this. And the purpose of which was to end up taking care of joint medical cases or patients' cases. So logically, we had to end up looking at a common patient's file. So nobody wanted the system. What about our 2 European deputies? Would they agree to push the right controls? So without disclosing any secrets there or any confidential information, this will arise out of the system. I can hear that the European Parliament can't do it all, but we can suggest a European medical patient's file, and I think this could be embraced. Now, 2 comments. That's hard work, because indeed the French national system, the NOI number card, carte vitale, very few people have managed to do that, to change systems at the nationals, other than national level, except Estonia, for instance. But I think there's not a reason not to do it. And second comment, if we do this, maybe starting from the cross-border regions that will probably do this, because European-wide medical file on the scale of the 27 member states, that's probably a utopia, I think. But working with neighboring countries, cross-border countries, might be a first step forward. And it is essential because patients travel, and that's the happy fews. Those chronically sick patients don't necessarily have the opportunity to travel for second opinions as well. But we could develop what we could call the European reference networks, and so as to share expertise, competence, skill sets amongst healthcare professionals, so as to allow some of the patients in cancer treatment or patients with serious and complex pathologies, they could have access to medical skills as well as medical resources to improve quality of healthcare. But it's a long way, yes, but it's a good idea. The commissioner, former CEO of Atos, he would be very, very much in favor of this. Why are we not pushing in that direction? And when we talk about having discussions when it comes to health care, we're not doing well at all. We're in some areas, maybe gimmick areas, we're doing pretty well, and it's terrible to push in that direction. I won't let go. I mean, it's. I think it seems that this is about how difficult it is to, from the part of the healthcare community, to change the way they work. We're not doing well in France on this matter, on this respect. There are better countries and more efficient countries than us. And we need to get inspired by these examples.
semble important, c'est-à-dire qu'il faut sortir du secteur de la santé.
Important words is that we need to get out, to move away from the healthcare sector proper, and we need to be more encompassing, more wide-ranging. And the bottom line is that data, when it comes to, is banking cards, data are very, very sensitive. They're very hardly violated, and there will be problems indeed, but still I think it is banking cards is interoperable around the world, and we could have similar cards for healthcare. For every one of our citizens, medical data, well, we could have a line whenever we have a medical consultation, let's say, an X-ray, and this can be, input into our medical card. And when we look at transactions in hospitals, at the end of the day, we have different models, we have different, some are state-run, others are private, others are international, others are local banks, but everywhere you go, your credit card's allowed to withdraw money, irrespective of money, performing transactions, and transferring money, so everything is pretty well regulated, and we should get inspiration from the banking sector. Definitely, we're not making any progress. We need to take this into account. We need to really take away those lessons and to move forward. And so we could contact BNP and say, well, what is the secret to your success? So yes, so this is what we want to do. Okay. What Antoine is saying is absolutely true. We want to be capable to automate in IT systems. I think, in my view, the science, and medical files that could be in this card, irrespective of countries we visit. This would allow to take care of someone having this information. So that's where the problem lies. We need to accept that the patient's files to be consulted by people across or beyond the borders of the country of origin. So access to data, it's the culture that we must overhaul. And they are potentially, potential impacts for our health systems that are significant. And we must facilitate this type of technical approaches. François and then Nathalie COLIN. François KRABANSKY first. Indeed, this card will allow to record the medical act. And what about reimbursement or healthcare coverage? And so when we talk about, because it is about the prices gaps from country to country, and so that's the first aspect. And how do you reimburse this? And then I share your view, and this will be about I go to any hospitals, something and medical and healthcare professionals in abroad can access all my medical history. So this will be different, bringing together all this data, maybe data hub concept. If we could have this powerhouse to have all of the data in terms of research, in terms of service offerings, and in terms of health data management, but so as to be on a par from a power of analysis, then private businesses, this would be a formidable tool on these European, this shared European medical file. This would be a tremendous progress, a tremendous step forward. We can't hear you. We can't hear you. We'll get back to you. Can you hear me? Yes, you're back. Okay. saying that on this this shared European medical file or record, okay, there has to be, we have to look at the protection of private data, particularly a sensitive topic in the field of health. As we said earlier, something that's really challenging to put in place in the 27 member states, but the eastern region in France is a cross-border region, and they're really experimenting many of these approaches. So I'd like to come back to the evaluation of healthcare technologies. I'd like to remind you that is a ruling that, notably because France and Germany consider that we have the best evaluation systems and don't want to hear from any mutualization, any pooling of services on this respect. So you're probably right. There has to be a bit of constraint at the level of member states. Obviously, we always end up in situations where we're stuck and bogged down on the evaluation of technologies when it comes to healthcare. Antoine is right. We need to go and see what's happening elsewhere. This holds true for banking groups. I was an intensivist, and I spent a lot of time looking for beds for my patients when I'm in hospital environments. Why have we not contacted hotel and catering industries? Because they know how to manage beds. And so this is their core business. They have core skills in that field. That's fundamental. When it comes to cross-border, this would be an avenue we could explore in Europe. Working population is 220 million, and 1% of which, 2.2 million, travel across borders to work. And all the medical data, it's quite surprising, they could be used to better purposes or in a better way. One point we need to be mindful of is that if our respective national institutions can't work, can't do any better, private operators might be more agile when it comes to prerequisites and requirements, when it comes to data, medical data protection. When there's illness, there are some sites where you need to register, and this gives you a possibility to have access to forms of discussions for people affected by similar diseases. And so my fear is that if we don't take care of this ourselves, somebody else will do it, and maybe not in such a rigorous manner. So member states that will, this is about member states happy and ready to work together. Now, next topic, and this will be subject to another roundtable tomorrow. I'd like to get the opinion of Nathalie KRABANSKY. She drafted a report for the European Parliament, and I'd like to get your views, to your take on things. Nathalie, a few words on the report. Nathalie Colin, the report you drafted. Yeah, the reshoring is one of the causes of the shortage, which has become more amplified with the crisis, the COVID-19 crisis. And one of the causes, one of the main causes of problems has been due to the relocation of finished drugs and active substances, relocation. So people have been talking a lot about reshoring that exceeds the scope of the national scope, and we need to entice and from a tax standpoint, businesses to reshore and re-establish their productions. Here, our deputy has gone offline. She will come back. Who wants to jump in and contribute to the discussions? Philippe, JUVIN. If companies relocate, unfortunately, they've been given reason to do that. and we need to look at the whys. So in terms of the costs, well, Jean Castex has a major project to reduce productions. There's 1,000 things that national players. So this is not about jumping on the table right away, but so offshoring would be backtracking. If we take the example of drugs, in Europe we've stopped including patients in clinical trials, and there's been why? Because we don't include patients fast enough, and the major clinical trials are mass clinical trials. So it's in a reduction of 25% of inclusion between 2014 and 2016. And in some of the examples I have in mind, so we have to address specific issues to, so on a multifactorial basis, all the way to clinical trials, and our capacity to be agile is in question. So we are societies that are less agile, less able to adapt to needs than industry. I've been involved in politics for some time, but I can tell you that 10 years ago, people would be told that the pharmaceutical industry would leave France, would be relocated. The priority would be to refocus on R&D, but we didn't get there for the reasons I mentioned. So Antoine, Sandy, and Véronique TRILLET-LENOIR in this order.
Juste pour dire que 80%.
Just to let you know that over 80% of antibiotics are produced by China. Europe, the US have been very reckless, and have been lacking caution when it comes to supply of active substances and letting active substances, most of these are being supplied by China. If they were to decide to cut those supplies, we'll be in trouble. And today, this is not about reshoring in France and the US this type of production. And I think we should diversify. There are other countries in Asia, Vietnam, Thailand, and they would have the capacity, they would be ready to do that. I think we need to turn to this type of diversification today, as opposed to considering reshoring of active substance production back on the national territories. And this would bear burdens on the already tensed medical healthcare systems. Well, the real issue is not about being able to produce in our countries. It would be very difficult to do that. It would be too costly. But diversifying is really something that we must do. And this is about many other types of drugs can have that. And I've worked a lot on very expensive, in the field of expensive treatments, and we need to continue to encourage research and development without preventing, without hindering research and development. And so, because if there's no profitability, then the industry will not be interested. Maybe some of the drugs coming into the markets are way too costly. So R&D, relocation of R&D, and access for the patient. Very well. Véronique, you wanted to contribute? And yes, thank you very much. And I'd like to, on behalf of Nathalie Colin, unfortunately she's left us what we do think, the two of us, about these matters. Reshoring will not address all the issues, but if we can reshore, then we need to diversify the means to do that. We need to try and move towards state aids, state funding, so as to encourage healthcare industrials to come back to European soil. We need to allow public health organizations to recover some of their manufacturing functions that they previously were exercising. And BADA, just to mention, is a public-private partnership model on vaccines, and the Commission and member states want to share financial risks and legal risks with healthcare industrial players to encourage them to reshore production. That's complicated still, but to maintain research and development over the European territories. These are just the key headlines driven by our joint proposals with Nathalie, COLIN, OESTERLE. Thank you very much indeed for these fine discussions, and we'll meet again in 15 minutes' time at 10:45 after a break for free hospitals, ? Thank you very much to every one of you. Thank you.